Hello, everyone. Thanks for joining. So I wanted to kick off our kind of ocular trauma series. And today's session specifically, we're going to look at chemical, thermal, and laser injuries. But in future sessions, we're also going to touch on blunt trauma, penetrating trauma, talking about globe repair, lid lacerations, orbital fractures, foreign bodies. We're going to talk about all the different kind of aspects of trauma that might come through the door in your sort of eye casualty. But today specifically, we're going to focus on these three sort of types of injuries, as they tend to sort of, I mean, the chemical and thermal especially tends to be a more sort of anterior segment injury. And then I just wanted to touch on very briefly the laser injuries at the end of the presentation. So we'll start off with chemical injuries. I mean, chemical injuries are really much more common than you might think. And actually, in most patients, they don't really cause any problems. You know, somebody's accidentally sprayed their eyes with some perfume at home, or for some reason, I've seen quite a lot of kids who've had like washing machine tablets just sort of pop in their faces while they're playing with them. Um, and actually, they can be sort of silent killers, really. So it's really important sometimes not to kind of immediately underestimate them when they're first walking through the door, because any sort of remnant of a kind of strong chemical can actually cause a lot of long-term damage if it's not appropriately managed. So think of your sort of strong acids, things like, for example, like battery acid, for example, um, and different sort of kind of cleaning fluids. Um, you've got things like uh, bleach, kind of oven cleaners, you know, all sorts of like fertilizers that people use in the gardens. So there's all sorts of different chemicals that can end up in people's eyes. So it's kind of important to bear that in mind, really, when these patients are coming in through the door, that actually in day-to-day use, there are some very strong alkalis and very strong acids that are actually in everyday use and can cause a lot of damage. So how do you approach these patients? Generally, you're probably going to treat them first, then ask the questions later. If somebody has come in through the door with a chemical injury, they should typically have their pH checked straight away and irrigated immediately. Um, and they really ought to be irrigated until that pH is normal. Then, when you have a sort of moment to sit down and speak to the patient, there are a few things that sort of should be going through your head in terms of stratifying the patient in front of you from a prognostic point of view. So, what was the pH of the agent that they used? Was it a solid one, a solid 14? How long have they been exposed to the actual injury? So, for example, that's both. Was it sort of, you know, poured onto their eyes, or was it a quick sort of drop? And actually, how long has it been since they've actually sought medical attention? Then, from the sort of clinical assessment, you're looking at things like the corneal involvement, your limbal involvement, and your conjunctival involvement. All of those have been proven in the literature to actually contribute to the overall prognosis. And is there any associated injury? Is this part of of an underlying of a sorry systemic trauma as well? And really, in terms of your main features that you're looking at, so you're going to look at the conjunctiva. Is it very inflamed, or actually, is it so bad the conjunctiva is completely white and ischemic? Do you have some ischemia at the limbus of the cornea? Any epitheliopathy? Do they have some stromal edema? Do they have a high IOP? Has their sclera started to melt? And in the more severe injuries, that's really quite important to look for. Um, and then in terms of sort of longer term problems, you're thinking about things like the development of cicatricial disease. That develops then into sort of things like lid malpositions and entropions. You're thinking about limbal ischemia, poor corneal health. Is this a patient that's going to actually end up with a physical eye because they've had just, you know, scleral involvement and quite severe chemical injury? So, even though you'll see a lot of these, and in the majority of them, they'll be very, very mild, it is important to have in the back of your mind things that you're looking for to determine whether or not the patient in front of you is in danger. So, really, it's mainly your cornea, your limbus, and the conjunctiva that will give you these clues as to whether or not the patient in front of you is requiring a bit more of a kind of detailed approach. So, In the assessment, there's sort of two main classification systems that you might come across. There's sort of the Roper Hall and the Dewar classification. The Roper Hall kind of looks mainly at your cornea, at your limbus, whereas the Dewar looks mainly at your conjunctiva. But both of them give you an idea of how severe the disease, how severe the injury is, and what actual sort of prognosis you're sort of thinking about. And generally, the sort of higher the classification, the worse the prognosis. And this is helpful when you're actually, thinking about what you're going to do for the patient, and what you can actually tell the patient in terms of what to expect going forward, because some of them may be very concerned, and if they don't actually have a lot of involvement, then you can sometimes reassure them. Or if you're actually noticing quite a lot of conjunctival involvement or a lot of limbal ischemia, you're letting the patient know that they require quite intense supervision, and they need to be making sure that they're coming in very regularly to the clinic to ensure that they're actually being treated as optimally as possible. I just wanted to put in a bit of a picture of a chemical injury that came in once to me. So you can see there's some chemosis, there's some inflammation around the conjunctiva. But generally, if you actually take a closer look at the limbus, there's not actually a lot of of limbal ischemia. The cornea itself, actually, the epithelium is intact. There's not a lot of conjunctival ischemia either. So this is generally a more mild chemical injury, but they can get much, much more severe. And when it comes to the management, anyone that comes in through the door with a chemical injury, like I said, immediately is going to be irrigated. They need to have their lids averted to make sure that that irrigation goes right down into the fornices. Their upper lids may actually even be double everted as well. You're going to test that pH after the irrigation, but sometimes it's actually also important to test it again, like a good 5 minutes after you finish the irrigation, just to make sure that they haven't actually, their pH hasn't either come back up or come back down after you've stopped irrigating, because sometimes you can get these sort of chemical particles within the fornices that will actually then bring that pH either back down to the acidic levels, or up to the alkaline levels as well. And you essentially want to just keep irrigating the eye until that pH has normalized. And then in terms of what you're going to send the patient home with, once you've sort of done the irrigation and that pH has normalized, they'll have an antibiotic. You may consider wanting to give them either in an ointment form to help with lubrication, or you might want to give them actually preservative-free drops, for example, some cycloplegia to help with their pain. And the lubrication is also really important. And it's just generally kind of throughout this, consider preservative-free options where possible. Then, with your more severe injuries, you might want to consider giving them some topical steroids, maybe some topical ascorbic acid. Obviously, only in alkali burns. You're not going to want to give someone with an acidic burn ascorbic acid, and you can actually also give it to them orally. Oral tetracyclines can again help with that ocular surface inflammation. And then if they're patients that have come in with high IOPs, you're going to manage their pressure in the way that you would manage any pressure. So you're going to think about the topical treatment to manage their pressure, and also some oral treatment as well. But remember that those pressure drops can actually be really quite toxic to the surface of the eye. So if you don't have those preservative-free choices, maybe an oral acetazolamide is much kinder to the patient than adding in quite harsh drops to a patient's surface that's actually already been damaged with a chemical injury. And then in terms of your chronic treatment, for patients with very severe disease, these are patients who might need amniotic membrane grafts, maybe conjunctival autografts for ischemic conjunctiva. They may need reconstructive surgery to their fornices, stem cell transplants. And for these more severe injuries, these are patients that are going to be referred into your corneal clinics, into your external clinics, and be considered for what surgical management is beneficial for the patients. And sometimes, actually, what they might need is, because their entire anterior surface, essentially the architecture is completely gone. Things like a keratoprosthesis. So a patient like this had come in. This gentleman had suffered from he was working in an ammonium plant, and essentially with a water injury, everything sort of exploded into his face. So it was a sort of mix of a thermal injury as well as a chemical injury. And you can see that his ocular surface had all completely gone. So with a keratoprosthesis, you can actually sometimes be left with very good vision if the posterior segment of the eye is actually unharmed. But the anterior segment is so bad that they require a keratoprosthesis. But if you can see in his left, it was unsalvageable. So he actually ended up having an enucleation in the left eye, with a keratoprosthesis in the right. So moving on with your thermal injuries. So thermal injuries, you can kind of consider them very similar to your chemical injuries, but thermal injuries sometimes actually present with, an extensive burn. So think about whether or not their mouth and their neck and their airways are involved. Do they have any breathing problems? Are these patients who ought to be under kind of intensive care unit? Um, and involve the sort of trauma colleagues, your burns colleagues. The patient might benefit from being in a burns unit, whatever your local one is. And then generally, you're sort of looking at burns in the context of total body surface area. So as a percentage of their total body surface area, the extent of the burn usually dictates what the sort of prognosis of the patient and how intensely they're going to need to be resuscitated. In terms of the actual ocular exam, remember to look at both your lids and the ocular surface. So, consider whether or not there are any lid injuries, any blistering injuries to the skin, any sort of full thickness burns. And then with the ocular surface, it can be very similar to chemical injuries. So you may end up with something like a corneal melt. Um, it can range anywhere from a sort of superficial, kind of punctate keratopathy all the way through to sort of corneal melting and perforations. So do take a close look at the eye, look at the conjunctiva, and see and check your lids as well. And you're essentially going to think about the extent of your injury in deciding, therefore, how to manage a thermal injury. And this is your sort of an example of a burns injury. You've got lots of chemosis, lots of hyperemia around the conjunctiva, this corneal burn, edema, neovascularization. You can see the lids are also quite starting to blister as well. So the burns injuries can really be quite extensive. And sometimes it's not necessarily just a direct burn, but also from the smoke injuries as well, which can give you chemical burns too. So remember that these are patients that probably require, quite intense systemic management. So they lose a lot of fluid when you've had lots of burns. So these are patients that are going to need quite intense resuscitation, skin care, systemic organ support. And then from an ocular point of view, think about your sort of ocular surface and the lid injuries. So from an ocular surface point of view, irrigating them with cool fluid can help settle that thermal injury. And then again, very similar to chemical injuries in terms of your antibiotics, lubricants, steroids, tetracyclines. And then with your lid injuries, again, cold compressors, lots of cold fluid as well to try and reduce that thermal impact. And then again, antibiotic ointments to the skin. But if it's very severe and they actually have dead tissue, then that sometimes needs to be debrided because that necrotic tissue can get infected. And then you might want to think about having the patient long-term considerations of things like skin grafting as well, depending on the extent of the injury and the loss of the lid skin. So finally, we're just going to talk about laser injury. So vision loss from laser can either happen because of an anterior problem or a posterior problem. So anteriorly, lasers can actually burn your cornea. They give you a kind of photokeratitis, stromal edema, and that can sometimes be temporary, or it can actually persist with stromal scarring. And actually, sometimes if the laser is strong enough, you can even just absolutely just puncture through your cornea. Or what you might come across more typically is actually foveal burns. So these are laser burns right back to the retina. And if they're anywhere in the macula or more central to the fovea, they can actually really dramatically cause vision loss. And really, the main point to make here is that prevention is always better than cure. And unfortunately, we'd be surprised from sometimes the laser damage that can happen iatrogenically. So from laser treatment when you're trying to do PRP, accidentally lasering the macula. So education on laser machines, maintenance of the machines, ensuring that you actually are, yourself are training yourself on how to apply laser to the back of the eye, but actually also educating patients in terms of what they do in the community and whether or not they work with lasers as a sort of occupational hazard. The corneal stuff can be treated. You would treat them as you would any sort of corneal burn, again with the irrigation, the topical treatments. But really, with the posterior treatment, unfortunately, once that retina has been lasered, there's not a lot of evidence to suggest that anything really helps with reversing any of that. Obviously, if they then develop any sort of fluid at the back of the eye, there are things that can happen that can be done for that, but the burn itself is usually untreatable. So that sort of brings us to the end of the discussion today. So we've sort of, discussed the chemical and thermal injuries, talked a bit about laser, and in the future sessions, like I said, we'll start talking about things like foreign bodies, blunt and penetrating injuries, orbital fractures and lid lacerations. So, there'll be a series over the next few weeks of going through the sort of ocular trauma. So thanks very much for joining. Please do remember fill out the feedback. There's a link in the description below, and thank you very much for joining, and we'll see you at the next one.